sayın hocalarım, değerli meslektaşlarım, EKMUD'un organize ettiği uydu toplantısına hoş geldiniz. Bugün çok değerli iki konuşmacımız var. Sayın Profesör Daniel Albert İsrail'den geldi. Orada Kaplan Medical Center'da alerji, immünoloji ve HIV/AIDS kliniğinin başında. HIV/AIDS ile ilgili çok sayıda ilaç geliştirme çalışmalarına katılmış ve çok sayıda da bu alanda yayını olan bir hocamız. Bildiğiniz gibi yavaş yavaş integraz inhibitörleri HIV tedavisinin omurgası olma yolunda. Bu açıdan biz hem klinik araştırmalardaki durumu Sayın Profesör Doktor Daniel Albert'tan öğreneceğiz. Daha sonra da Cerrahpaşa Tıp Fakültesi İnfeksiyon Hastalıkları ve Klinik Mikrobiyoloji'den hepinizin çok iyi tanıdığı Doçent Doktor Birgül Mete bize integraz inhibitörlerinin gerçek yaşam verilerini sunacaklar. Ben ilk konuşmayı yapmak üzere Profesör Doktor Daniel Albert'ı kürsüye davet ediyorum.
Thank you. So, first of all, thanks the organizers and thanks Gilead for inviting me. And it's really a great honor to be here in Turkey. And my task is to start this symposia and talk about a little bit of the clinical trials on ART, especially on Stribild. Okay. So starting from the beginning, we are now living in an area that is very exciting. So for those who remember or those that learned about it, we are living now in about 20 years after HEART was introduced into our life, into the life of our patients. And in '96, when HEART received the nickname of cocktail, it was actually giving about 12, 15, 17 pills a day, 3-4 times a day. And we passed really a long, long way during the years since, since '96, when the first protease inhibitors combinations came into the life of our patients, until recently when we have a lot of options of treating HIV patients with quite simple regimens, of single tablet regimens, of less side effects, very effective drugs. And this leads us to the next slide, talking about the evolution. And this is just an example from the DHSS guidelines, telling us that treatment of HIV patients that was at the beginning only for those patients that were really ill, those with below 500 and then below 350 copies or even below 200 copies of CD4 counts. So now we are dealing with treating all patients, and we are in the era of beyond undetectable. We do not treat our patients just for their viral load. We treat our patients because we understand there are long complications of inflammation. We're treating our patients because we know that they infect less other people while they are virologically suppressed. And this came into practice, especially because our drugs are potent, are effective, have few side effects, and our patient can tolerate them for a long time. And what is the ideal drug? The ideal drug we are looking for is the drug that is very potent, that is effective, have no side effects. Especially, we prefer it to be a single tablet regimen, once a day, no drug-drug interaction, no food limitation. Actually, we're looking for a glass of water once every time. And what happened in clinical trials looking at new HIV drugs, new HIV treatment, just during the last 10 years, while we have very good antiretrovirals for treating our patients. And we can see that those drugs that are partly used still today, like Calitra, efavirenz, at the beginning of the 2005-2006, we have trials looking at them, and the threshold of success was a lot of time was about 50, 60, 70%. But if we look at on trials and very restricting trials with very restricting laws who is failing treatment, we can see that trials of Stribil, trials of dolutegravir now are looking on 90% success. And if we look at really patients that are on treatment, not just failing treatment because they have a snapshot of one viral load that is in the upper limit, we can reach even 95 or 100%, close to 100% success. But when we come to choose for a treatment, sometimes we try to choose between components, and we try to compare components. We take the very strongest component and try to say who is more effective, who is more efficient, who has less side effects. But sometimes I think actually our patients are not treated by a single agent. They are treated by a combination. And the combination sometimes it's what it counts. We choose between regimens. And from the picture you can see that I'm Argentinian. My club is more happy the other one. So looking on strategies for treatment and some studies that were in the past, we can see that naive patients, for example, the studies that looked at naive patients for Stribil are the classic pivotal one, the 102, 103. The studies were published already about 5 years ago, and those studies was for registrational reasons, and compare Stribil in a double-blind, placebo-controlled, randomized trial. In 102, it was compared to Atripla, is Stocrine plus Truvada. In the 103, it was compared with Atazanavir, Ritonavir, Truvada, that were the main standard of care treatment at the time. And you can see easily that in both trials, if you look after 3 years of treatment, Stribil versus Atripla or Stribil versus Atazanavir-based regimen did quite well. It will show non-inferiority. It reached the goal for registration. And really what happened after those trials were published, that Stribil was registered and recommended as a first-line treatment together with other integrase inhibitors, also in the DHSS guidelines, in the VIVA guidelines, in the EACS guidelines, actually worldwide. And we can see in the next slide that when looking on hard to treat populations, those with a viral load above 100,000 and those with a CD4 count below 350, again, Stribil show non-inferiority when used with versus Atripla, Stocrine and Truvada, or Atazanavir. Looking on the efficacy of CD4 count increase, again in both studies versus Atripla versus Atazanavir, Stribil showed good results, non-inferior results. And when looking on adverse events, we can see that actually they were comparable in the two studies, except of the creatinine and kidney thing, that I will mention it in a moment. But remember, this was the first study using cobicistat as a booster, and the understanding of what cobicistat does to the kidney was just at the beginning. Laboratory abnormalities that led to discontinuation of the study were similar in both studies, in both arms, regardless the use of Stribil versus Stocrine-based regimen or Atripla, or Atazanavir, sorry. And regarding the kidney issue, and I will come to it several times during this talk, the kidney issues, remember, this study was the first time use of cobicistat as a booster. And the understanding that cobicistat, what it does, it competes on the MATE1 transporter on the kidney. And actually the rising of creatinine and the rising of EGFR that is calculated with the creatinine was the reason of a kind of a cosmetical rise in creatinine and in EGFR that it's not represent a true tubulopathy or renal disease. And we can see that this occurs during the first 4 weeks of treatment, then it's stabilized, and actually this is not a sign of disease. This was very good to understand after that, because in the next studies it was considered a non-adverse event. A second thing that was raised at the time was the bone density issue, especially the use of atazanavir with Truvada, that is lowering the bone density, and it was actually also affecting real-life clinical fractures. But comparing Stribild in the 103 to atazanavir show that the effect was quite similar or even less, even though it didn't get to statistically confidence. So, concluding the two studies, Stribild had robust and durable efficacy through week 144. It was comparable efficacy to a 3+ Trocrin plus Truvada or atazanavir-based regimen. The consistent efficacy was across demographics, different groups, age, sex, etc. Stribild was associated with a low rate of resistance, and the resistance also was an issue, and it was found actually patients in 102 and 3 that failed and got resistance had some background resistance before starting study, so actually they didn't get 3 drugs, they got 2 or monotherapy with abeltegravir. Stribild was associated, was well tolerated even after 3 years of treatment, 144 weeks. And relative to 48, there were no cases of proximal to property or other further increase in creatinine. And overall, the long-term efficacy, safety, and tolerability support Stribild as an effective regimen treatment of naive patients. And this was, as I told you, the reason why Stribild was considered to be a first drug line choice for most of guidelines. Then they took Stribild into a very dangerous challenge, because when you want to take experienced patients and you try to give them a new drug, changing from a stable regimen to a new drug, actually you're taking a chance. And we saw that in the past, while Merck did the switch study, they couldn't show that raltegravir was good enough to continue treatment. There were a lot of troubles with that study at the time. But the thing is that taking patients that are suppressed on the treatment, they are feeling well, they are doing fantastic, and giving another drug, you take a chance that you can fail. And the Stribild team, what they did, they do several studies in this way. The first one was taking Stribild in those patients taking a protease inhibitor-based regimen and creating an open-label fashion 2-to-1 continuing Stribild or taking Stribild or continuing with the PI regimen. The reason that patients agreed to participate in the study was that part of them wanted to decrease or simplify current regimen to less pills. This is the most. Or some of them were considered and having some concern about long-term side effects. The group was mainly of men, and as you can see, after 1 year of treatment, there was actually a great success of treating with Stribild, with 94% of the patient being undetectable. And it was surprisingly even not planned for that, but it shows some kind of superiority when considering it and comparing it, continuing the regimen of the protease inhibitor. There were actually no emergence of resistance in either group, as we know already, but patients that are taking their medications are not failing. There were no adverse events significantly in both arms, and again, as I told you before, the change in serum creatinine and EGFR was consistent with the inhibition of MATE1, and actually it's much more a cosmetic thing occurring during the first 4 weeks of treatment. There was an issue regarding lipids, what happened with lipids, because we knew that protease inhibitors have some lipids problems, so changing to Stribild bettered a little bit the lipid profile, but the small number didn't allow us to get to a statistically significant change. The second study was actually the same study, this time led by Jose Rivas in Spain, and he took patients that were stable on an NRTI, and remember, stable patients that were taking medication, happy with the medication, feeling very, very good, and changing them to a Stribild regimen. Again, the reason was some patients wanted simplification, some patients were afraid of long-term concerns about the treatment with the NNRTI. Most of them were men. And again, the results were fantastic. So we had more, and we look again on studies on nowadays that show efficacy of above 90%, and but at this time the significance wasn't statistically significant between the two arms. There were no true emergence of resistance to integrase inhibitors in both arms. There was some resistance, but a mutation that was not clinically important. And the adverse events were similar in both groups. Again, we can see the rising of cobicistat, the rising on EGFR and creatinine. And looking versus the efavirenz on lipid profile, we can see that the lipid profile overall was better, but not getting to a statistically significant, but at least not worse. So in conclusion, the switching even to from an NNRTI stable patient or PI patient was successful with maintaining the virological suppression and no difference in adverse events in other things. The last one was taking, and this time they did it a switch in one arm, switching from patients that were stable on an integrase inhibitor, but it was raltegravir that was taken at the time twice daily, and switching them to Stribild. It was a single-arm, small study, but show again this mainly men, and show 100% keeping the viral suppression. So with no other adverse event of all grades, again the creatinine, the renal things, and the fasting lipids, and saying that in conclusion, also in this study, we can say that changing from an integrase inhibitor at this point was raltegravir to Stribild all subjects remained virologically suppressed with no adverse events, no change in serum creatinine that post-switch, and no relevant clinical changes in lipids. The last thing about experienced patients is a work published last year in Glasgow that an Italian group took patients that were stable on their current treatment and changed them either to dolutegravir or to elbiterravir, and we can see that the results were quite good with both arms. There was one virological failure with elbiterravir, but on the other hand, there were more patients that were stopping treatment because of adverse events in the dolutegravir arm, but both arms did well. So even comparing to dolutegravir, it seems that it's fine. The last few slides in my talk, I will just remind you an issue of integrase inhibitor and tolerability, especially neuropsychiatric side effects. This is a thing that for those of you that are now going to international conferences, it's more and more rising, especially with dolutegravir, because it started 2 years ago in Glasgow when a group from Netherlands showed that there's some issues with neuropsychiatric side effects using dolutegravir. They weren't sure if it's a class effect or just dolutegravir. It rose a lot of questions between investigators and physicians treating HIV patients. So, and this is a group from Germany that look on the 3 different integrase inhibitors and try to look if it's really a thing of discontinuing treatment because of neuropsychiatric side effects in the dolutegravir arm. And the neuropsychiatric adverse events were common in all 3 groups, but they were most common in dolutegravir, resulted in greater discontinuation. This really rose the thing. I know that the people from VIV are looking on data, and one of the things they look again on all the pivotal studies of dolutegravir, showing that there indeed were some issues regarding neuropsychiatric side effects in all the studies, but none of them in the pivotal study didn't go to discontinuation of the treatment with dolutegravir in those pivotal studies, in the versus dolutegravir or darunavir or efavirenz or atazanavir. But again, another group from Germany look in a prospective method what is happening with patients that are treated with dolutegravir, and the issue of stopping treatment because of neuropsychiatric adverse events rise again, and this is really an issue that is bothering. It's important to understand one thing. Nobody says dolutegravir, and we are in a Gilead symposium. It's important to understand that nobody says dolutegravir is a toxic neurocognitive or neuropsychiatric substance. But there is an issue, and it should be in our considerations, between other issues. And several studies, this is a slide that tried to conclude all the reports and the studies that were during the last year talking about neurocognitive or neuropsychiatric side effects that were regard to the use of dolutegravir. And in the last CROI, 1 month ago, a Spanish group did the publication of taking all the integrase inhibitors regimens that are available right now. There are 5 of them, 2 with dolutegravir, 2 with raltegravir, and 1 with the elvitegravir, and comparing from for the neuropsychiatric adverse event leading to discontinuation. And they conclude that there was a significant higher rate of discontinuation due to neuropsychiatric adverse events with dolutegravir versus raltegravir or elvitegravir covisistat. And the last thing that was published also in the last CROI was a Japanese group looking and saying that they think there's a correlation between the levels of dolutegravir in the blood and neuropsychiatric adverse events, saying maybe there's something there. But again, and I will conclude with that in the next slides, we didn't reach yet the glass of water. So we as physicians have an arsenal of drugs to use. And when we're choosing the right regimen for our patient, we can have drugs that maybe there's some drug-drug interactions or some comorbidities interactions, or maybe there are some drugs that are not taste so good, but all of the drugs are potent. And when we want the drug for the patient, we want really not to be in this way, but to have we have all the tools for a tailor-fit suit and choosing the right regimen for our patients. Thank you.